Okay, so you know who I am. I've got quite a few slides. I'll whiz through quite a few of them. Don't be upset. It just means that you'll hear about it later on, or we can... Are we emailing these? So there will be a copy available as such. So a lot of it is just visual. What I say might be more important, but I doubt it. But between us, we'll get it right. So in terms of prevalence, we know that actually with age, you're more likely to end up with atrial fibrillation. Men are more likely to get AF compared to women. And we've got an ageing population, so this is becoming a big problem. We've got at least 1 million people with AF. And depending on which paper you read, it could be as many people who are asymptomatic that we know nothing about, or even more than that. I've taken a slightly local perspective, and these are data from the I think it's from the SEN. Jean, it is. So I'll give you credit. So we've got data for East Lancashire. This is East Lancashire CCG. We've got nearly 60-odd practices. And when we look at sort of prevalence data across the practices compared to, this is going to go fade in and out again, isn't it? Compared to the local national prevalence, there are quartiles in terms of upper and lower. In essence, what this tells us, there's a huge variation in terms of prevalence across practices. Now, part of that could be a reflection of the fact that you have a different age population group. So you have a younger population, and therefore that's what it's reflecting. It might be actually other reason for that, but our feeling is that actually this might be because there's just a different level of awareness within practices. So we're not capturing the patients that are actually out there. And when we look at, I guess the major outcome is the risk of stroke. And when we look at data from our hospitals in terms of prevalence of underlying risk factors, so this shows atrial fibrillation, hypertension, and the risk and the number of patients who are on anticoagulation before they're admitted. And there's a variation across Lancashire in terms of the prevalence. When I look specifically at East Lancashire in terms of prevalence of hypertension, AF, and the proportion of patients who are actually on... Can you actually hear me without this? Because I get a little bit disconcerted. Can I put the microphone down? Can you still hear me? Is that okay? Right. At the back, can you hear me? I just need a bit of a wave. Otherwise, I'm thinking you can't hear me. You're just being polite. Thank you very much. Fab. So in terms of anticoagulation, there were roughly about 60% of patients who have AF are already on anticoagulation, but about 40% have come in without it. When you look at study data, roughly about 6% have undiagnosed AF when they present with an ischemic stroke as such. But if you actually do something like a 24-hour ECG or longer sort of monitoring, that 6% goes up to nearly 20% of patients. So there are lots of patients who are probably not being diagnosed with AF, who are going in and out of hospital as having AF related to ischemic heart disease or hypertension. But the reality is it's becoming a more complex world. In primary care, we're dealing with a very complex population. It's very easy to get focused on a condition, but when we see patients, they have lots of problems. So they might have diabetes, they might have asthma, they might have COPD. And as much as I like gadgets, and as much as as a GP, I want to take on innovation, the difficulty is often about what do I have to give up to take on what I'm doing now? So what do I have to release doing in order to meet the demands and expectations about what's necessary in terms of our population management? So on a daily basis, I don't think I'm really busy. It's a case of how do I make myself more effective in terms of what I do? And as a practice, 20 years ago, you would probably have a GP, and if you were lucky, you had a nurse. We've moved on in terms of having GPs, practice nurse practitioners, healthcare assistants, receptionists who more than just clock in and clock out patients. And innovation is such that there's probably technology being used. The two things I'm not going to talk about today in terms of technology is the fact that across East Lancashire, we have EMIS Web as a centralised process for recording information. Now in there are tools such as ChadVask that are part of our QOF recording information. So automatically we know who our patients are with atrial fibrillation. We've got a register, and we know whether they need to have their CHA2DS2-VASc score worked out or not. And the other tool that we've all invested in is in Aristotle, which is now allowing us to look at data not only at a practice level, but across a whole health economy. As a CCG, I can look at all my patients across my 59 odd practices and know how many of those patients have atrial fibrillation, but more importantly, how many of those patients also have diabetes, hypertension, obesity, asthma, COPD, in terms of all the QOF registers, and additionally, whether they've been admitted to hospital with a stroke or been to outpatients or had recurrent episodes of going into A&E. Now that's really becoming very useful data that we haven't got a handle of yet in terms of how to use properly, because we're still getting used to it, but potentially has a big impact in terms of how we start commissioning better. Now, in terms of hypertension, the 2011 guidelines around hypertension mention the fact that actually there is difficulty in monitoring blood pressure in patients who have atrial fibrillation, and that makes it difficult to know how to use ambulatory blood pressure monitors or home blood pressure monitors, because not only does your pulse vary, but your blood pressure varies with it. So the easiest way for me to pick up atrial fibrillation, you would think, would be to touch and feel somebody's pulse. But the reality is that's the one thing that's hardly ever done. I went through the effort of going through a cardiology clinic recently, and believe it or not, the nurse didn't check my pulse. You have the blood pressure monitor put on, and that tells you your pulse, and it tells you your blood pressure, and they might stick a thermometer in your ear and get your temperature as such. And the cardiologist didn't check my pulse, but listen to my heart. I guess he would have picked it up from there. But the feeling of the pulse seems to have been an art that went away with I don't know who, but we certainly don't seem to be doing it as much, and we're relying on technology. I don't necessarily think that's a good idea per se, because we don't necessarily have the technology that's there yet to be able to tell us whether somebody has AF or not. There is something that NICE recommended, watch BP Home, and when you look at the data around this, there's lots of papers saying yes, you know, you can use this device to monitor blood pressure, and yes, you can use this device to monitor atrial fibrillation in patients who might have paroxysmal, intermittent AF. But there's no papers saying that actually you can monitor blood pressure well in patients who have AF. So you still have to rely on the old manual manometer to be able to tell you what their blood pressure is. You can't use a digital monitor. And you'd be surprised how many practices don't actually know that if somebody who has AF, you should be monitoring their blood pressure manually. Where's their protocol? Look at the protocol. Something to do, Jean. So in terms of atrial fibrillation, the NICE guidelines have already been mentioned. And I don't know how that well comes across, but there is those people who like to work through algorithms. There is a good one. And the first part of it is all about looking at how should we be monitoring AF. And now the highlighted bit I was going to highlight was do not screen asymptomatic populations. There's no evidence to show there's any benefit from monitoring or screening for asymptomatic patients. And you have to rely on symptoms in terms of breathlessness, palpitations. But there is evidence that about 50% of patients or population might be asymptomatic to their symptoms in a sense. So they're walking around with AF and not knowing that they have AF. And it's worth thinking about how we opportunistically grab those populations in terms of knowing that they might have AF, because actually there is some benefit from treating those patients. They're still at greater risk of having ischemic strokes. So in terms of the guidelines, it does mention the fact actually there are certain groups of people that you should be opportunistically detecting AF in, and those are patients who have underlying hypertension, diabetes, ischemic heart disease are the guys that they've said. Obviously, if you look at CHA2DS2-VASc score, it's patients who are over the age of 65, particularly men who fall into this category of being more likely to benefit from being screened. Oh no, I use that word, opportunistically detected, and potentially benefit from being diagnosed with having AF. In terms of, there are some other issues in terms of what, and this picks up on the question about, actually it's quite difficult. You have to go through a number of hoops and steps in terms of managing it. I think the guidelines do make it simple in terms of saying, actually, do we need to do blood tests? They say, you don't have to do blood tests, but most people will do a full blood count, use an ease, and maybe their thyroid function. Do we need an echo? Only if you need to change your management of that person. So if your CHA2DS2-VASc score is +1 in a man, the chances are you're going to anticoagulate irrespective of whether they have a problem with their valve or they have a problem with their chamber in terms of how well it's functioning. So do we need to refer? Now that's a tricky bit, I guess, really, in terms of when you talk to the cardiologist, and we probably have one in the room somewhere, say, well, if as soon as you detect it, you should be starting them on anticoagulation. And whether you go for a NOAC or warfarin while you're waiting for the 12 weeks before they get seen in the clinic is the issue, I guess, in some respects. It's worth thinking about the risk factors. In terms of developing AF, as I mentioned, hypertension, ischemic heart disease, heart failure. But more importantly, when we've looked at the data in terms of the Framingham Heart Study, this was only published last month in the Lancet, what they found that actually obesity and diabetes are becoming important underlying risk factors for patients, and that we probably need to be targeting or be aware of certain population groups, because this is an increasing problem in the general population anyway, but the overall increased risk is greater for this particular group, along with patients who are on treatment for hypertension as well as undiagnosed hypertension. So those three groups make up a large, significant number of patients who are more likely to develop AF. I won't go through the detail, you can read all of that. The SAFE study is the one study that was randomized controlled trial that was done in primary care that's looked at opportunistically screening for patients in primary care using nurses and then confirming the diagnosis using an ECG. And the conclusion from their strategy was that actually it does work, and there's approximately a 60% of annual opportunistic screening being cost effective if you target it to a specific group of populations. So in East Lancashire, we've been working through two gadgets, I guess. So one of them is a live core. I've got the old version. You can see the newer version over there as such. And there's been roughly about 30 practices out of the 59 who've taken up the opportunity of using this. And so far, the feedback has been actually, in terms of GPs who love gadgets, it's quite handy to have when you're going on a visit, for example, and you just need to have that quick, this pulse is irregular, is it fast AF, or is it something else? It works on an acoustic system, if I'm correct. It's not actually measuring any electrical pulse. It's just measuring the pulse, your sort of the acoustics from a pulse. Is that right?
Not quite. No. It does use electricity to measure, and then it converts it to a sound signal from the microphone on the phone.
Right. Close enough for me.
Yeah.
I'm not that gadgety. I guess the important bit is the practicalities. So the reality is you can hold it and be able to do it in practice or while you're out on a visit. And you'll get a trace that you can actually, and if you have an NHS account, it's the ability to be able to safely transfer that information to your NHS email back to your base for analysis or send it off for analysis. And that's a typical example of the sort of printout you can get from the device. It's not worked as well in the nursing home setting because that's it's a bit of a struggle for some patients to understand what exactly you're supposed to do. And if you have some sort of tremor, it makes it quite tricky for the interpretation element in certain group of populations. The other device has been My Diagnostic, and again, the device is at the back. And we're testing this, I guess, in terms of funding from the AHSN, but also in terms of the CCG, in collaboration with the UCLAN. And the aim is to look at the feasibility of using this as opportunistically. And we're doing it in 3 different settings. Once in primary care, the other one is through pharmacies, and the third is in care homes and nursing homes. And the objectives are quite clear for me in terms of saying, well, actually, does it work? Does it work at a patient level? Does it work at the professional level? But does it work also in terms of the commissioning, pathway of, does it make a difference in terms of being able to detect patients early enough to do something about this? In terms of the primary care element, and I've got some data in terms of, we've just gone through the pathway, how do we do this in practice? Who's the person who's supposed to be taking or using this device? How do we record that information? How do we share that in terms of being able to make a decision about what happens next? So one of the things we've had to do is really to have that leaflet as part of the patient who's turning up. So we're targeting patients who are over the age of 65 who are coming in for a routine appointment for either a blood test or blood pressure test or whatever through the healthcare assistant. And part of that is saying to the patient, look, we're testing everybody using a device because certain people are more risk of stroke. And these are, and I couldn't get the other side of the thing, on the back it gives you the risk factors in there, and that includes atrial fibrillation. So we need to be able to check your pulse to know whether you have an irregular heartbeat. And that's part of the education. Education is an important element because a lot of patients aren't aware of the risks of stroke as being an underlying risk factor. And our hope or our assumption is actually if you're coming in for healthcare advice and intervention through a blood test or blood pressure monitoring or whatever, that you're far more receptive about knowing your risk factors and getting the appropriate advice about smoking or weight loss, or knowing about your underlying risk factors related to your irregular heart rate. So the healthcare assistant's job is to basically to get an acceptance from the patient to say, yes, we'll do it, and she will code that in terms of having had a test done. And then it's a case of saying whether we have an irregular heart rate or not. Once that machine says no, i.e. the red light comes up, we have an internal process saying, okay, look, this shows that you might have an irregular heart rate. We need to do a proper ECG, and we can organise that for you now. And we're able to do that within the practice of being able to sort that out and sort out an appointment. And that's a critical element. There isn't necessarily a delay of more than a day at most, and saying, look, I can't do it right now, I can do it tomorrow. And once that ECG has been done, it's important that we get feedback from somebody within the practice who can actually interpret the data and say, well, actually, yeah, that does show atrial fibrillation. We'll need to sort out an appointment for you to talk to the doctor about what we do next. So an important element of that is being able to sort out the pathway, but also in terms of how time-consuming it is. But just giving out the leaflet is time-consuming, because it isn't a case of saying, look, here you are, go read about it. It's about interpretation. Do you know what the risk factors are for stroke? It's asking questions in a way that allows the patient to engage with their own understanding and being able to give back information in a way that makes sense to them. So that's a number of patients I've got over the age of 75. I don't have of the number of patients over the age of 65, but clearly it would be more than patients who are over 75. In total, we've got just over 64,000 patients in East Lancashire, so I'm presuming it'll be about 80,000 at least. And in terms of care homes, we have nearly 100 care homes with over 3,000 patients. In pharmacies, this is a potential really, I think, in terms of, I have no idea how well it's going to be, how effective it's going to be, but the reality is that we have over 100 pharmacies in East Lancashire, so more pharmacies and practices, and most of the patients will be going through pharmacies for routine medical collection. We already have incentives in terms of having their blood pressure checked. We do a number of the health checks in terms of vascular health checks through pharmacies as well. Can we add to that an ability for have patients to check their pulse and understand a little bit more about their underlying risk factors? but we need to sort out the pathway of actually, if that stick says you might have an irregular heart rate, where do you go next? How do we sort out the next bit in terms of which is the practice? How do we sort out the ECG? How do we sort out the relevant tests that might be required after that? So I have results from one practice. I'd let you guess which one, which is roughly 6,000 odd patients. We've been trialling the diagnostic. Oh no, did I say we? This stick has been tested for about 10 months in terms of that pathway of the patients being asked whether they want to use the stick or not. And we managed to get through 400 patients. We have a prevalence of about 2%. The number of negative tests is 380, so that's a green light on the stick. A number of positive results was 14. Of those, number of it doesn't show up actually, I must have got it wrong. The number of diagnosed with AF was 3 in terms of having an ECG that showed that they have AF. The other patients, the other 11, all had an irregular heart rate, and some of those actually needed further investigations in terms of having a 24-hour ECG or an echo because they had some sort of ventricular arrhythmia or some sort of conduction disorder that needed further investigation. Believe it or not, 8 patients actually refused to have the test. And guess what their gender was? Yeah, they're all men. They didn't want, they were happy to have the blood tests, they're happy to have their blood pressure monitor, but they didn't want to know whether they have AF or not. And that's really interesting for me to know in terms of where people are in terms of the perceptions of risks and why monitoring AF or knowing your pulse might not work at a football game. You know, when you're going out to enjoy yourself and you just want to have a good time and 8 pints, why would you want to know about your risks of having atrial fibrillation? There are some real challenges that we need to kind of address. There are further things we want to do, and I think it is that kind of process of actually, I've made the diagnosis. Do I go for NOACs? Do I go for oral anticoagulations? And how does it fit? We have a number of patients within the practice who have bought their own machine in terms of monitoring their INR, and we do give out the sticks because we think that's where they need to be. They're quite happy to take control, and they can work through the protocol, and they can email their local anticoagulation clinic or turn up if they insist and go through the numbers and be able to go through what they need to do. But the reality is, the GP, although I might not be starting them, I am prescribing on a daily basis medication that interferes with their warfarin, and I really should be aware of the risks and benefits of being on that, and I'm making decisions for that patient on a daily basis about which antibiotics to give or not. So moving the shift from secondary care to primary care is happening across so many different pathways. The complexity is such that actually we need to move it a little bit further and get patients far more involved in their own care, but we face quite a few challenges along that pathway. And this is just the beginning. And taking on Aidan's point of, you know, where do we go with this? And the reality is actually we need the flexibility of innovation within primary care to test out ways of moving things forwards. It's easy to have a top-down approach to say, look, this is what you must do. But we tend to pick on ideas that work. The difficulty often for us is how do we share those good ideas? How do we get the fact that actually this is a much better way of doing things across? And this is where I think the AHSN might play a bigger part in picking up good ideas and saying, okay, you know, we worked out the costs of this as in a health economy. We know how to deliver this in terms of a CCG if you want to commission this. You know, this is how it's worked in this health economy. This might be a way it might work in yours. I as a GP, I wouldn't have the capability to go around sharing good ideas, but I could feed into a system that allows us to do that. Now, I haven't got a clue whether I've answered any of the questions that you put, but at least I gave you a chance to air those. But I think I might still have some time. Have I still got some? Oh, go on, please, please. Damn.
We've got one more speaker before.
No. Cancel them. I'm still here. All right. Cheers. Thank you very much. All right.